just so we have your name. This is a public meeting, so we do need to take account for attendees.
Hi, this
Good
is,
morning.
I think it's Sarah Ponce, but I don't know why it's coming up null void. I haven't changed my settings, so I could log out and log back in. I have no idea why.
You can just, hey, Sarah, just rename yourself. Just click
Okay.
the little blue button with the ... It says rename, and we've got you. Glad to know it's you, Sarah. And oh, we got Dr. Zender. And Lauren, good morning.
Good morning.
Hey, Lauren. Hey, Brian. So we've got 1, 2, 3. I think we need one more.
Yeah. There we go, Brian. We got you. And there's
Brian,
Katie.
where are you? You
Here
look like
comes
you're
Katie.
calling in from the space shuttle.
Yeah, I'm in my office.
And there's Katie.
Great. All right. Melanie, I do think we have a quorum. So to respect everybody's time, we'll go ahead and get started. Now, forgive me as always for just having to read through the formalities, but I'll try and keep it a bit light. So first 5 minutes, remember, this is not an induction of anesthesia, so try and stay awake. Although this might substitute for if we run out of propofol here somewhere. All right, so I am Perry Fine, chair of the Cannabinoid Product Board, and I will call this meeting of the Cannabinoid Product Board to order on at 9:03 on September 14th, 2021. So I think that substantiates my orientation to person, place, time, and situation. That happens exactly once a month now. So this board's purpose has met half of its intent. This is being held virtually by the Department of Health on behalf of the Center for Medical Cannabis based here in Salt Lake City, Utah. And public notice of this meeting was provided as required under Utah's open meeting laws, and it was posted on the Utah Public Notice website. In compliance with Utah's open meeting law, this meeting is being recorded. A recording of this meeting will be posted to the Utah Public Notice website no later than 3 business days following the date of this meeting. Written minutes will also be prepared of this meeting, and approved minutes will be posted to the Utah Public Notice website no later than 3 business days after board approval. With that, Melanie, I would like to ask you to do a roll call of the board members, please.
Do you want everyone just to unmute and say their names?
Perry Fine.
Brian Zender.
Catherine Carlson.
Dr. Chair, I think you have your 4 board members.
Oop, did we not? Did we lose Lauren somewhere?
There was a simul response with Catherine.
Oh,
and
okay.
Lauren.
All right. There's Lauren. Okay, great. And as ever, I would like to draw everybody's attention to those individuals on our from the Department of Health and the Center for Medical Cannabis. Especially noteworthy, of course, is our Executive Director, Rich Oborn, and Dr. Woolsey and Melanie Shepard for their great work over the last month. They work very diligently behind the scenes to make all of this a reality and to work smoothly and keep me on track. So thank you very much, one and all. Now, as a courtesy to and for procedural reasons, if you have a comment, please raise your hand. And if you are not a member of the board, but a member of the public and signing on, you will have an opportunity to comment. And depending upon this context, I'll either call on you during the meeting or afterwards, make sure that everybody has a voice in all these proceedings. Otherwise, please continue to be on mute. And with all that, we will now proceed to the agenda, which I'm going to pull up real quickly here.
Hey, Dr. Fine, I just want to remind people that raising hand is under the reactions icon. You click that and that's where you raise your hand or lower your hand. And then we have a request from Katie Carlson to have people identify themselves.
Let's see, I'm just trying to move things around here a bit. Give me one moment.
Dr. Carlson, would you like them to do that in the chat or would you like them to introduce themselves? We're not a large group, but we can do that by either way.
Well, Katie, I think just for procedural reasons, as long as everybody's identified on screen, which they are, that suffices. And then if you do have a question or called on for discussion, then you can provide a little background if you're a member of the public.
Got it. Thanks. That's good.
Okay, I just need to struggle here for a moment and pull up the agenda. Here we go. No, I'm not being able to click and drag here. So we do have the minutes available and they've been posted and the board has had a chance to review them. If there are any additions, comments, corrections, please do let us know what those are now. Otherwise, I'd like a motion to approve, please.
This is Brian Zender, so moved.
Is there a second?
This is Misty Smith. I second.
Sorry, I just
Okay.
had a question about the minutes. Very minor thing I just noticed at the bottom. I just wanted to confirm, it might be correct, but it says that Melanie Shepherd will send Misty Smith the PTSD document and the epilepsy document. Misty presented on epilepsy. Were we sending her the PTSD document as well?
I received the epilepsy document.
So maybe we
I
could,
think you're right to strike that PTSD, Lauren.
otherwise it looks great.
Okay, I'll note in there that it's approved with that off of it.
That was already approved. Sarah, did you have a comment? Okay. Anyway, is there a need for a correction there? If it's just a glitch, then we can correct that and move on.
I made a note in the notes.
All
and
right,
so
I'll assume that then. Okay. So if that requires correction, we'll correct, and if any comment, otherwise, I'll assume that's an approval by assent. Any vote, any no votes? All right. Well, we now get to the heart of the work effort of this group, which is the review of indications for the use of cannabis for medical purposes. And I just wanted to make note of the extraordinary progress we've made over this last year that will be summed up by Rich in a little bit when we get to the annual report. But we've gone through really virtually all the major indications, or at least the approved conditions under the legislative act for the use of cannabis in the medical cannabis program. And we have a few more to go. Starting next month, next month in October, we'll have a review, a deep dive into cancer pain, which is sort of a subset of the chronic pain area, which I touched on a little over a year ago when we began this process, maybe a year and a half ago. And that'll be an update by Dr. Dan Odell, who is one of my colleagues at the university and works at the Huntsman Cancer Institute on the supportive oncology and service and the palliative care and pain service there. So with that one completed next month, we're on for review. That will bring us through this calendar year, and then we'll proceed with a few of the sort of the stragglers, if you will, as we get into the new year. But our business today is to review the Alzheimer's document that is now, I think, ready for approval. Or any discussion, happy to entertain that. I think there's been ample time to review. And then we'll move on to the epilepsy document that Misty Smith presented and then summarized and documented in a format that complies with sort of our proceedings as we've now sort of made them official. So are there any discussion? Yes.
Would you like me to display that document or just for discussion?
Well, I think since it's been posted, let's just see, first of all, if there is any need for discussion. If anybody wants it displayed, that's fine. We can get into it if we want, but hopefully everybody's had an ample time to review it. Are there any concerns, issues, discussion points that anybody wants to bring forward? Dr. Viner, I see your hand up. Let me just make sure nobody else on the. All right. Dr. Viner, please.
Hi, just one quick comment. And under recommend.
Mark, could you just please introduce yourself again to the group?
Oh, yes, Mark Viner, MD, physician, psychiatrist, private practice. Under the recommendations, I was just wondering in general, should you put comma, yeah, like for example, insufficient evidence to support or refute, blah, blah. Would you say in comma, unless you're enrolled in a clinical trial, should that little part be included when we vote, when you vote generally against its general use for some disorder? So for the Alzheimer, what if it's an old person who's not competent and there's a clinical trial and they want to get enrolled in it?
Yeah, clinical trials are obviously a special circumstance, and this is these documents really pertain to well, two things. One, these documents pertain to the medical cannabis program, which is independent, obviously, from a clinical trials circumstance. Also, the clinical trials always is a sort of a waiver of any indications or not. In fact, there wouldn't be a necessity for a clinical trial if there was already ample evidence, if you will. So I appreciate the thought and the comment, but I think that would be, in fact, it would probably confuse people at this point more than anything. I think we're trying to be as concise with these and direct those who are recommending cannabis products for clinical purposes and specific conditions in this state. So, but thank you for the thought. Anyone want to weigh in, please do. You know me, I tend to be not shy. Okay, well, glad, and thank you all for taking the time to review this. Well, we've really made an effort to get these things out to you timely and to have ample time for review, and you all have been very good at sending comments and allowing us the opportunity then to do these in timely ways, and we seem to be getting more efficient as we go along here. So with that, may I hear a motion to approve the guidance document for Alzheimer's disease?
I move to approve.
So moved, and is there a second?
Second.
And a second is heard by Dr. Heath. Thank you. All in favor, please signify by saying aye. You'll have to unmute to do that.
Aye.
Aye.
Aye. Any opposed, say no. You'll have to unmute to do that. Any abstentions? And make note to unmute if you want to abstain. All right, we will then consider this document approved and the date of approval will be noted on the document, and then it will go into the, as part of our website guidance documents for clinicians and obviously for the public. And this will be included and noted in our report. We'll now move on to item 4, which is approval of changes to the guidance for epilepsy. Dr. Smith, I hope that you've had ample time to review this and either agree or refute my ham-fisted attempts at editing your superb review, and that the board has had ample time now also to review the changes. There were not a lot of changes, which I think speaks well of the original effort to review this going back now almost a couple of years, and to provide it as a guidance document as the program got underway a year ago, March. So any discussion with regards to the epilepsy document?
This
Right.
is Brian Zender. Just a couple minor changes. Anytime we use like a three letters like DUI or AED or CBD, the first time that it's in the document, it probably should be in parentheses with the full name before you refer to it in shorthand. So someone might just want to go through the document and clean that up a little bit. I had to think carefully about AED before I knew what it was.
Which one are you, Brian? I couldn't quite hear you. Which one?
So AED is anti-epileptic drug, obviously. but I couldn't
right.
remember that's what it was off the top of my head. So I know that if I was thinking about that, there would be other people that would read it and not know.
No, that's a very good point, because it's certainly that one could be confused with an automatic electronic
Right.
defibrillator. we wouldn't want to confuse the two. Although,
So just the first,
Yeah.
someone might want to go through the document and then just
right.
define the three letters for each of them that are in there. I mean, DUI is pretty obvious, but again, it's just part of writing.
No, you're absolutely right. Standard editing protocol. There's the the standard formatting for publications should follow that. You're absolutely right. So Melanie, could you just go ahead? That doesn't obviously change content, but if there is
Well, and Perry, if I can add one thing.
sure, Missy, of course.
If we're going to do that, we should be consistent with the American Epilepsy Society guidelines. They've moved away from the use of AED. Since there's no true anti-epileptic drug, we have anti-seizure drugs. So the appropriate acronym is ASD for
Okay.
anti-seizure drug.
And I tell you, what do you guys think about in view of the fact that this is sort of a shifting nomenclature? Why don't we just spell out anti-seizure drug any place where it's indicated to do that? Melanie, are you okay with going through and making that change?
Yeah, I had actually already changed a few of them. If I missed one, that.
Yeah, and I can't remember. I did try to do some just word editing for that purpose, and I probably missed it too if Brian picked up on it. So thanks, Melanie, if you would do that. And barring that one minor editorial wordsmithing, any further discussion about content?
This is not a content comment, but that was a good pickup, and it brought my eyes to the page 4 where we refer to AEDs, which will now refer to anti-seizure drugs. So maybe this won't apply, but we're using the possessive, the apostrophe in a couple of places. I'll glance through, but it's just a grammatical error.
Yeah, the only place I know where possessive is actually the possessive apostrophe is used in defining a condition that where we've applied it as Alzheimer's disease, and the other would be Parkinson's if we've
Okay.
done, if that's, and So there are a few places where that possession, but otherwise correct. That would be a grammatical or
Yeah.
a
So
issue.
maybe just when we're going through looking at the abbreviations, we can look through for that.
Sure. Good point. Dr. Viner, I see your hand up. Or that's a new question?
Yes, can you hear me?
Yes.
Okay, in the gray box, one quick question. Do you think we should put, I think, it's for the when you have CBD/Epidiolex, with the exception of CBD/Epidiolex, there's insufficient evidence, but do you think we should put, it was confusing when I was reading it. It sounded like a CBD isolate, like a just CBD. So maybe we need to put the pharmaceutical formulation of CBD, because it's a little bit confusing to a doctor who's reading it. And if you say pure CBD, you want to probably put pure plant-derived CBD, which leads me to the final comment. Do you think we should have, this is the first marijuana derivative that FDA approved for anything in the US for the 3 disorders it was mentioned. So I think it deserves a special sentence or two. Epidiolex is approved for seizures associated with blah, blah, blah. Outside of that, we don't, you can put blah, 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 what you already written. But I think it's important to at least mention it because it's so historically significant. When the DEA, approves a marijuana plant-derived product for the first time, not counting Savitex in Canada for pain. This is the real first indication in America where it's been approved, the marijuana plant-derived pure CBD derivative. So anyway, I don't think, and it's not even mentioned in the epilepsy report. And it's FDA approved for 3 disorders for 1 year old or greater, tuberous, with the Dravet and the other one. So anyway, I just think it would be important to put in the green because it's a term, it doesn't sound like it's really approved for anything in the gray box. It's just my opinion reading it as a practicing doctor looking for guidelines. But okay.
So it's really so it sounds like, Mark, it's really a clarification issue rather than a content per se. Misty, when you look through this, then hearing what Dr. Viner's saying as a person outside sort of the group that's sort of used to reading this stuff all the time and thinking about these terms, we really do want to make sure that, especially not only the public, but people in the medical community who are not as familiar as we are with all this are not confused and do understand this. Could you just take a look at that, Misty, or comment now if you feel like you want to, and maybe split the sentence and say basically that Epidiolex is an approved formulation of plant-derived CBD in sesame oil for use, blah, blah, blah. Other than this, and then they'll proceed with basically the disclaimer. Does that make sense to you, Misty, or do you have other thoughts?
No, I can add a statement about its approved indications.
Okay. In view of the fact that this is just a clarification and not a content change, I don't see any reason to delay vote by approving this document for yet another month. So given the clarification that will be made, and that's within that vein, are there any other discussion points with regards to content?
I just wanted to say the only reason I didn't overtly state that is it's actually stated in some of the articles that are referenced.
Right. Yeah, I think it's always good. I mean, just as a general point, and I appreciate Dr. Viner, you're mentioning this. Most people are really not familiar with almost anything about any of this. There is no formal education per se. You have to really dig around in literature to read stuff. We are serving that purpose in many ways. We are, in a sense, the educational body with regards to cannabis used for medical purposes. at least in the state. And since other states, and Rich, you can maybe speak of this a bit and remind everybody, are actually looking at us and what we're doing here in Utah and hot linking, if you will, to our documents because they haven't been able to accomplish similar things in their jurisdictions. So that's a very good point. I do note that Alzheimer's, actually, the I and E got reversed in the agenda. I think that's just a typo there, but let's make sure in the document itself we've got Alzheimer's spelled correctly. We don't have a we don't have a budget for actually a paid editor for our works, so it's just all up to us. We are the editor. All right. With that all said, may I hear a motion to approve the guidance for epilepsy update?
I move to approve.
This is Brian.
So moved. Is there a second?
Second.
A second is heard. So all in favor, please unmute and say aye.
Aye.
Aye. Any no votes, please unmute and say no. Similarly, any abstentions, please unmute and say abstain. Hearing none, the motion goes forward with approval, and Melanie and Misty will just make that clarification, and we'll move on from there and then publish this accordingly. Thank you all. That's very good work. That summarizes the last few months of effort on everybody's behalf here. And again, my hat's off to all of you for your help in doing this. And that brings us up to date with until Dan Odell's presentation next month on cancer pain. So Rich, I'm going to turn the podium over to you metaphorically here, and Sarah as well, of course, to comment on and remind everybody about the relationship. I think it would be helpful, since we've got some new ears and faces, the relationship between the legislature, the Department of Health, as that operates under the aegis of Utah government, but is a branch of the executive branch, right? And some of their changes being made within the Department of Health now, as well as then the Center for Medical Cannabis, which, if you will, lives by legislative language within the Department of Health. And then we, of course, as the board, lives within that sort of collective. So Rich, I'd like you to sort of, and Sarah, if you will, sort of summarize all of that relationship, and then how we report out to the interim Committee on Health and Human Services in anticipation of the next legislative session, how this process works, and some of the key issues that we're trying to bring to that body's attention with regards to ourselves going forward. I know that's a mouthful, but we've given you ample, just take it away, and we'll listen avidly. Thank you.
Sure. So as Dr. Fine indicated, I'm Rich Oborn. I'm the director for the Center for Medical Cannabis at the Utah Department of Health. And it is the Center for Medical Cannabis is established. One of our key responsibilities is to provide administrative support to the Cannabinoid Product Board. The Cannabinoid Product Board has existed since 2017, and there's been a lot of work that's been done since the beginning of that existence. And at this point, right now, one of the primary responsibilities has been making updates to some suggested guidelines that by statute, the Cannabinoid Product Board is to create and maintain and make updates to over time as more research studies are evaluated and new information is gathered and input is received from experts regarding the use of cannabis. And so for a period, Sarah Ponce has provided some general support to us, and also Melanie Shepard, as our executive assistant, has helped us put together with help from Dr. Sarah Woolsey. She's division director of the Division of Family Health and Preparedness at the Department of Health. We've put together this first draft of the annual report for 2021. And this first draft that's been posted on the public notice website, it summarizes the purpose of the board at the very beginning, and then it goes through some of the decisions that have been made throughout the past year. And it summarizes some of the presentations that have been made during the past year, during the public meetings that have been hosted by the Cannabinoid Product Board. And it also summarizes some recommendations that the board is making. And when it comes down to it, one of the primary purposes of the board is to make recommendations to the legislature regarding medical conditions that respond to cannabinoid products, and to also make any recommendations related to cannabis use guidelines that are being recommended for providers throughout the state of Utah that recommend medical cannabis. And we've been very fortunate to get some input from the providers on the board, but also national experts that we've been able to evaluate their studies and take those into our consideration as a department, and also members of the Cannabinoid Product Board. That kind of gives you a general high level purpose of the Department of Health as it relates to the Cannabinoid Product Board and the Cannabinoid Product Board itself. And I think we're happy to share on our public notice website a rough draft of some of the work that the board has done as summarized in the annual report. And I think I'm happy to go through some additional specifics that appear in that rough draft, if that's helpful to individuals on the board. I know you've all had a chance to take a look at this as it's been circulated, but if you feel like that'd be helpful, Dr. Fine, I'm happy to do that.
Well, I'd like to actually give Sarah a chance to sort of weigh in too, and help us all understand, her role in all of this. But there will be an opportunity, I believe, if everything goes as it has in the past, for to make a presentation that'll be virtually like this over Zoom to the interim Health and Human Services Committee meeting. It'll maybe about 5 minutes. It's a very brief presentation. We'll make some PowerPoint slides that will summarize really the key issues. We've done a lot of work this year. You have done a lot of work this year, and I think some special mention needs to be made that let these folks know that you are a voluntary body. You put a lot of time and effort into, and thoughtful effort into, supporting the health and well-being of our fellow Utahns, as well as the medical community and the health community, if you will, at large, to have this program be a success. And so I think it's important that we interface with this committee, and the committee in turn can provide feedback to the legislature about this, this very important piece of legislation that they created after the public weighed in so heavily with regards to wanting a program like this in the state, and the unique features of what we have done, not just to depart from, but we think to try and advance this field in very responsible ways on behalf of the public health, to bring science and the most important principles of medical practice to this process. So all of this has gone, largely behind the scenes, and this is our one chance, I think, every year. If I'm not to sort of let these guys know, these guys and gals, the generic guys know that what's going on. purely voluntary, that you all, your collective time is very valuable. And you're doing this because of your good citizenship. So that's a little bit of a, of a speech, I know. But I feel very strongly about this and the importance of recognizing your efforts. And truly what a superb job I believe that Sarah, Rich, and their staff are doing, taking this very seriously. This is just not a cavalier process. We take these duties very seriously. Sarah, do you want to ice that cake if you would? I would love to have everybody hear your voice too and hear your thoughts on this.
So, hey, Dr. Fine, do you mean Sarah Ponce or Sarah Woolsey?
Oh, Sarah Woolsey. I'm Dr. Woolsey, the esteemed
Okay.
Dr. Woolsey.
Yeah, no, you guys, just so you all know, there are 3 Sarahs on the Center for Medical Cannabis. And we want to make sure we get the right ones. So Sarah Woolsey, I'm a medical director advising with Rich on the Center for Medical Cannabis, in addition to being the Family Health and Preparedness medical director, division director. And I would just say coming in February and learning about the power and academic prowess of the board members, as well as representatives like Dr. Zender that represent our family physicians that are in the field, advising and making sure proper education for his staff and making sure that we have good guidance for anyone recommending. I think you guys have a very respectable and tight process, and I'm happy to support that and continue to advance the good work that we've done, and just have the legislature know that, again, we have tight processes. We have academically appointed and prescribing clinicians that are advising the work that we produce, and that we do it in a standard way, and that we'll review that as the evidence changes, and we'll continue to improve our program. So I think with this product board, only that speaks for itself, and we will do our best to continue to make sure people know this as a resource. As Sarah Ponce and I have worked on educational pieces, and Rich as well, we have added reference to this in all the physician education, so they know this is the source of truth for Utah clinicians to look at, given the fact that this is an emerging field. And then the second thing I will mention, like Rich had said, we commit as the staff to listening to your input on how to make this better, how to ensure that the things that you're working on are smooth and as professional as possible. So when taken to task, our documents, our website, our public meetings are top notch, and can stand and show the good work that's been done. So that's all I have to add. And Perry, I think you get to be the tip of the spear and present to the interim committee, and we will make sure that again, we sing the praises of this group that you've led so well.
Thank you. It'll be my pleasure and honor to do so. And Theris, thanks you. Sorry, I really appreciate that. I think your voice in this does add and position adds gravitas to what we're doing. So thank you. And
Thank
Sarah
you.
Ponce, all due credit where it's deserved. So take a bow, if you will. If you want to say a few words and as you accept your Oscar, but you don't want the music to drive you off the stage. Anyway, anything you'd like to say, Sarah, please do. But we'd love to hear your voice.
I just wanted to say thank you for allowing me to help participate in this. I think the information that we gather is it's invaluable to our patients and to our qualified medical providers. And I'm happy to participate in any research I'm interested in as well. And I really, the work that you guys have done here is really great. And I thank you for all your hard work.
Thank you, Sarah. And as we get to the last agenda item, we'll talk a little bit about what we're anticipating going forward with education and research and so forth as to as things are still in developing and rapidly evolving mode. We can maybe touch upon where we think we'll get some maybe progress in year 2022, which when you think about it, it's we are now what, Rich, about just a year and a half into the program. It's really quite remarkable where we stand. And with that, I wanted to bring forward Sarah, Melanie rather. Can I, or is it possible to share my screen with the group? Can we do that?
Yeah, you'll just have to click your, just a second here. If you click share screen at the bottom there.
Got it. Okay,
Dr.
we're ready.
Fine.
Ready for me? Great. Okay. Let me pull this up then. Okay, can you all see what I'm looking at? Which is the recent cannabis use in myocardial infarction document.
No,
You got it. All right. I wanted to bring this forward for a little discussion.
Here, Dr. Fine, no, we
Yes.
cannot see it. We cannot see it.
You cannot see it. I wonder why not.
And Melanie, maybe if
Want
you could
me to
get
share it?
it posted. Yeah.
Is it the one that you emailed me? Which one, which document is it?
It's entitled, it's a PDF entitled Recent Cannabis Use in Myocardial Infarction in Young Adults. I don't know why. I'm not sharing. Let me try again. Share screen. Pull up the document. Okay. I don't know if that's mine or Sarah's, but whoever's can everybody, oh, that's Melanie or Melanie.
Got it. Yeah.
Gosh, everybody's named Sarah now. In fact, I'm just calling my daughter Sarah. That's because it's everybody's Sarah. All right. Thank you, Melanie. So I trust everybody else can see this. I know there's a lot of literature that I don't see, but I'm making an attempt to sort of try and go through, especially through PubMed and other sources where peer-reviewed publications are coming out, and to stay abreast of those, as well as there's some various sites that provide updated information. You can sort of filter those. And so this came across my purview just a couple of weeks ago, and it seemed that of all the various things that come around, a lot of it's interesting. It's not just noise. I mean, it's interesting, but it doesn't add appreciably to the body of knowledge. And so when you stumble upon something that does, I think it's important for us to share it. And you guys certainly, anything that finds its way to you, bring forward and send to either Sarah Ponce or Melanie Shepard, and they can forward it to me or through Rich or Sarah Woolsey. But anyway, that way we can have these sort of discussions during our board meetings, or collect a few papers that are not completely necessarily pertinent to the materials under review for the guidance documents. This one seemed particularly pertinent, that it's a very well conducted, methodologically sound evaluation of risk with results that do raise some eyebrows. Unfortunately, when I looked at how this was presented in more sort of lay materials after this publication went out, as you say, it was embargoed until September 7th last week. The lead picture was actually of a joint, and of course, smoking is not part of our program, so it easily could have been dismissed. But what the study indicates is that yes, even though smoking, combusted marijuana, cannabis is the highest risk, vaping is also a risk, and oral enteral absorption of cannabinoids, of cannabis materials, extracts, are also a risk. And so it seems to me that this is something that we should A, discuss, and B, as part of that discussion, I think we should include as a, if you will, a board discussed point and an item of concern to bring forward to the Interim Health and Human Services Committee, just to let them know that there is now a new risk potentially that heretofore has not been considered, and that we will at some point, we'll probably, as these things become reinforced and there's other studies, want to comment on this in a more formal way within our documents. But I think we owe it to those who are following the program closely and responsible for allowing the program to go forward in the state, which means there is exposure. And we know there is now greater exposure to people who view, as a result of this, cannabis as medicine. That, like all medicines, there are risks, and this is now considered potential risk. So I would love to just open up for discussion, any thoughts you have, and then we can talk about it administratively, how to handle this maybe at the end, but any and all comments would be welcome. Just go ahead and raise your hand, and Dr. Viner.
Hi. I think it's good to include serious heart-related adverse effects like myocardial infarction and also stroke and actually death. Just like the JAK inhibitors just got slapped with the black box warning in rheumatology, like Xeljanz and Rinvoq. Those have a same warning. They just got warned. And because there is good data. There's also that it helps. It's like people after they've had a heart attack who did it improves quicker. But I think this is significant and we should include it. In fact, I have patients I pre-medicate with beta blockers who have to take high dose THC for other reasons. So it affects dental procedures and surgery. Like you got to watch ketamine, epi, and these other drugs that can cause, say, tachycardia in these type of patients. But the bradycardia from the CBD and the tachycardia, those from THC, those are just examples. So I always include it. And I don't think we should shy away from saying that there is a potential for serious heart-related adverse effects. And possibly look at the stroke work and include that, and then just say death. You have to say it sooner or later. Okay, thank you.
Thank you, Dr. Viner. Since none of these are, if you will, FDA-approved products, they don't go through that kind of scrutiny of safety and efficacy, with safety really being obviously the leading edge of what FDA is there to do in anticipation that there may be a positive therapeutic signal for whatever medication they're reviewing. So this then, in a sense, falls to us. And, perhaps over time, we'll get to the point, and with ample staffing to be able to do the kind of deeper dives into the literature to look at safety data in a more comprehensive way, which thank you, Dr. Viner, for mentioning that, because that may be a direction, and I'm suspecting it's a direction we will also want to go. Dr. Smith, I see your hand up.
I would just mention that there is preclinical evidence to support this on both the cardiovascular effects of THC, specifically the increases in blood pressure and heart rate. So that could be referenced as well.
Misty, do you happen to have those references handy?
I don't have them handy, but I could look them up.
If you can do that with the next, we could do. I think what we'll do, perhaps Rich and I will just work on just a sentence, if you will, to add to maybe one of them, or one bullet point in one of the slides in the presentation, and then one sentence in the report that says there is ongoing. One of the roles that we are also taking as a board is to review safety data as it comes, as we're able to obtain it. And there are issues with regards to cardiovascular risk that we do want to draw attention to, because these are some new studies, something of that ilk. So Misty, a couple more references would be great. And I think what we'll do is, and Melanie and Sarah Ponce, I think what we should do is now create a little repository, if you would, maybe a little file somewhere hidden on the back side of one of your document screens or whatever of these sorts of references and reports as they're brought forward. And then we can maybe start thinking about them and compiling them over the next year, especially if we do get some more staff support and doing research to do this. I think that's an important part of our public health sort of mission here. Great. Thank you. Thank you, Misty, for doing that. Lauren.
Yes, I just wanted to, I had a couple comments about the article. I agree, it's a pretty, like the most robust study I've seen to date on this particular topic. And I also found it interesting how they were able to separate out the method of administration of the cannabis. And as Dr. Fine pointed out, the point estimates for vaporization or other also suggest that there could be increased risk of myocardial infarction. Previously, evidence I've seen has mostly been based on those who smoke cannabis, which in this study was still 76% of the people included. But I just wanted to add that for the other methods of administration, the point estimate of around 2 suggests increased risk, but it wasn't statistically significant, and the confidence interval is very wide. So I would just say that there's definitely a signal here, and it goes along with other evidence, but I would say we, given the wide confidence interval, there's still some uncertainty about that association, and we probably, in the future, I'd like to see more studies about looking at this risk, like maybe in a cohort study beyond this cross-sectional study. The other thing I wanted to add, just in case we weren't aware, is that I recalled that in our document, we do have a statement that exists about the risk of potential increased risk of cardiovascular events, including myocardial infarction and stroke, in otherwise healthy young individuals, which the study also seems to support that risk. And it was mostly based on, I think, case series or case control studies. So we could consider adding this study to modify that statement that we already have existing in our guidance document.
Thank you, Lauren. Katie.
Yeah, actually, Lauren, you said what I was gonna say. We have that, warnings, risks, and adverse effects section. It's on page 17. And we have about 25 sections, and 2 of them are exactly what Lauren's saying, but and I support that, adding, updated, not just for cardiovascular risks, but in all of the risk areas, adding updated significant research as it comes out. But one of the things this has popped up and then I forget it just over the years. When I go to the website, to the medical cannabis program website, it's really hard to find the information that we created. I mean, I'm on the board, and I every time have to start pressing links to see if any bells start ringing. I'm sure if I went on it every day, I'd know exactly where what I'm looking for is, but I'm wondering, especially when it comes to risks and side effects, do we want to have something more prominent that's almost hard to avoid? It's just hidden in the links, and it makes it look like it's kind of not really for the general public, or even, I know it's for providers, but I don't know. So I throw that out to the group for maybe future thought.
We agree with you there, Katie. That's something that we've wanted to make a priority. And I know that as we pick up some additional staff members just here in the next few weeks that we'll be able to dedicate more resources to making those changes. That's something that we're aware of, and we're glad you're emphasizing and noticing that same need. We agree with you there.
What I hear you guys saying, Lauren and Katie, really is an important sort of consumer. It's not only just for qualified or people who are making recommendations, but this is a really important consumer issue. And the idea, I think, one way to crystallize this going forward, and Rich and Dr. Woolsey and I can talk about this maybe over the next while as we sort of think about our scope of work for 2022, as we sort of finish up our first levels of reviews that we've now pretty much exhausted of the current indications. I think we could do a couple things. One is obviously we want to pull out the whole document now and look at it and see if it's really up to date and is it formatted in a way that makes sense and is findable. The other would be, I think, a process that would be very helpful, and we can discuss this now, but I think I'd like to bring this forward with Dr. Woolsey and Rich Oborn, thinking about what we can do in the new year, is actually have more of a consumer and health professionals driven, not like advisory board in a formal sense, but what's the term that we bring people together and ask them their get their sort of view. So what I'd like to do is maybe see if we can bring forward some some medical providers who have been using this, involved in the program on a regular basis, a focus group. Thank you. Whoever is helping my brain here, thank you very much. A focus group. Those who have used the program, those who are thinking about it, still contemplating, but haven't really bought in yet, and why the reasons are, but also consumers, people again who have if they're as a process that the health department could help us with, and ask them to look at our materials and how sensible they are, how readable they are, how coherent and cogent they may be, so we can really shape this. It may be that we need two sets of documents, one for health professionals, one for the consumers, but I don't see anything urgent about this. But as we move into the second year, moving into the third year of this program, I think we continue to refine this and make it much more user-friendly, and make it less difficult for all of us involved in any way, shape, or form to be current about this rapidly sort of evolving field. So we can have that discussion more in depth online. I see Rich shaking your head. I think this is what it means to be sort of part of a public health movement, is whether it's this or with preventative care in cancer, cancer screening, immunizations, although that's obviously a loaded issue these days. But how do you get smoking cessation, dietary stuff? These are how can we become part of that larger process and make it move along in more coherent ways. It may require a little funding. We'll be thinking about that going forward. So those are my thoughts. So obviously, Lauren and Catherine, Katie, rather, thank you. That activates some pathways and neural networks that we can now translate into some action. And I know Rich is excited about doing this sort of stuff too. So I'm just sort of thinking out loud. Any other thought? Lauren, your hands up still or again?
Oops, that was not on purpose.
Oh, okay. Any other discussion points at this? I'm just glad to see that this sort of piqued your interest as it did mine. I think this article sort of sent a signal that we need to reevaluate in this sort of a way. So great.
Dr. Fine, could I just share something of emphasis?
Of course. And Melanie, can you go ahead and take this down if you would, and then Rich, I'm sorry, so yeah. I can pull up some other things. Thank you.
Great. So one thing that was emphasized in there is that frequency of use matters. And so I think that's a message that we need to continue to remind patients and providers and pharmacies and anybody in the cannabis industry that's participating needs to just be reminded of the issue of just how frequency of use really matters, especially with minors and young adults. And especially when you're using those products that have the high amounts of THC, the frequency of use is something that needs to be really carefully monitored. If you're serious about using it medicinally, that's how to get the best medicinal use out of it is, and to avoid the long-term effects is be careful about the frequency of use.
Yeah, that brings up an interesting point. A lot of the studies, and I know Dr. Viner has looked into this in depth as well. And so your thoughts about this, Mark, I'd like to hear. But a lot of the studies that look at cannabis use in an effort to separate out medical from recreational, also look at frequency of use and whether this is a occasional recreational use, occasional use for medical indication or need. The person who uses it occasionally as a sleep aid or whatever, versus as part of a medical regimen for ongoing management of, and then whatever. And the critical point you were making, Rich, is that when we are using any drug for medical intent, other than on a quote PRN basis, this is chronic. If you're dealing with chronic condition or chronic disease management, there will be a frequency of use that may greatly exceed any evidence or database or clinical trials information we have in a longitudinal way. And so we are going to probably start seeing some new signals coming forward, and it's important to make note. And also the other variable here is not just the route of administration and the frequency of use, but the dose. And we often don't know exactly, certainly in previous studies or case series, necessarily what the dose was. There are not a lot of PK/PD studies out there. And those that exist are only mostly looking at THC, with a few now, very few, which I've reviewed extensively on CBD, and maybe some new ones. And I think we've heard mention of them with regards to cannabigerol and some of the other cannabivarin, some of the other cannabinoid constituents. But there are also terpenes, terpenoids, flavones, et cetera, a lot of other constituents. So it's hard to make definitive conclusions when you don't know what it is all these variables are. But if people are taking stuff once, twice, 3 times, 4 times a day continuously, that's a big differentiating position. So that is a point I think underline and underscore.
Yeah.
Mark, did you have any thoughts you'd like to? I'd literally invite your thoughts, because you have seen a lot of folks and think about this a lot, I know.
I'm going to jump in before Mark. I'm sorry.
Oh, Katie, sure, absolutely. I didn't see your hand. Sorry, Katie.
I didn't put my hand up on the screen.
Go ahead, please.
Sorry. Apologies for that.
No worries.
What you just said, Perry, I think you've actually, early on when we were writing this document, I think we had discussions, and I remember some comments from you about that. And I think, I think it's such an important point. And Rich, I appreciate that you brought us back to that. But, this is the challenge with making a non-FDA addictive substance medicine. It's true for benzodiazepines, for opioids, for stimulants. You habituate to taking it, and that changes the neurophysiology of your brain. And if you're an adolescent or a young adult, it's remarkable. And yet here we are with every single approved condition, I believe, is chronic. And we're, so this is the, that's just inherent in working with this substance. it's really challenging and of course, always more harmful on the more vulnerable people in our population. So I appreciate this and I look forward to kind of, now 3 years later, seeing how we can grapple with that.
Yeah, that's great. Thank you, Katie, for underscoring that. And, other than with the exception of chemotherapy-induced nausea and vomiting, yes, these are all chronic conditions. Some are chronic progressive conditions, but they do require, if you will, maintenance therapy. We're going to strive avidly to get a much better handle on what's actually happening out in the field with refinement of our database over time. That's a big point of discussion and action going forward. We're avidly working on that. So we may actually really learn something, both on the risk and the potential benefit side. So this is a tremendous opportunity. I'm glad to see there's so much interest and excitement, and we're not handling this in a passive way. The royal we, if you will, collectively, this is a tremendous opportunity. So thank you, Katie, for reminding us of that. Any other board members want to bring up any points? And Mark, again, you've been really a good loyal member of our fan club here. So please go ahead and share your ideas.
Well, I like Richard and Catherine's comments. Catherine, the best example is having when someone tries to stop who's been using it for years, and watch what happens to their sleep. It takes a month or two, but it can really mess the person up bad and lead to other psychiatric problems, just the sleep problem that can develop. And that's noted in the withdrawal criteria. And Richard, yes, the frequency is very important. But some of this MI, there's some different populations. A young person who just started cannabis really needs to be educated so they don't hurt themselves. Because if they try to do a very strong THC initially, you get the tachycardia, the blood pressure, but then the body gets used to it and the tachycardia decreases after a few weeks. So there's risk factors in young people, and also we can't leave out elderly because they get myocarditis. There's a whole bunch of vasculitis issues, myopathies, ischemia. So there's other issues, and just an older person. You saw that article referenced the lollipop that the old man had, and he went into asystole, bradycardia, and almost died because the CBD binds to adenosine receptors and causes bradycardia. Like for the medical doctors, Adenocard, that medicine in the ER you give for a tachycardia. The CBD does that too. So you got to look at the person. The frequency is very important. And like you were saying, Dr. Fine, the dosing and the frequency is totally different if you see for medical patients. So you're going to end up with all kinds of new side effects and issues you got to deal with. And then it comes time to where you actually got to lower their cycle of use. And that gets tricky too, because when you have a high level and then you drop it down, there's all kinds of things that pop up. So yes, I think those were great comments, and thanks for asking me.
Yeah, there may be a little group we want to put together in the new year as well, and maybe Melanie, I don't know if this needs to go in the minutes or not, but certainly in that little box you keep on your screen of files of things to do and think about, guidance on discontinuing or reducing cannabis use is something we probably want to refine and think about, and maybe put together a little separate group of individuals. Mark, you may be called to participate, but with Dr. Red, who I think had to miss today's call, I don't see him on, or Dr. Zender, others who have experience with this. there, some serious and significant mistakes were made. Unfortunately, some led by the CDC with some real strong lobbying, unfortunately, that led down a bad pathway by the CDC in terms of guidance with regards to opioid use and morphine, milligram equivalents and this sort of thing. And just a momentary digression, I participated at the request of the FDA in one of their advisory board this summer, looking extensively at this issue, both in terms of what science there is to bring to that, but also the public health adverse consequences, including deaths, that resulted from really bad advice about how, if people are on, for instance, chronic opioid therapy, how to deal with that in the age of the quote opioid epidemic. They really didn't separate out responsible prescribers and patients from those who were misusing, abusing, and how to parse the data and how to deal with people who were responsibly and effectively using medication, but then were essentially cut off. And there was as Katie Carlson probably knows, there was a significant uptick of suicides and some serious adverse events. We don't want to reinvent that wheel when we deal with our cannabis program. So this is something I think, again, it's a big public health issue. We need to take it seriously, address it scientifically, and we may want to make that part of our scope of work, perhaps in the new year, with bringing a group together to think about the review of the literature, and if the literature's not highly directive with evidence, at least some good common sense and experiential sort of consensus on how to do that. Again, and the last part of all this, in my view, it's a big black box that is not going to be within our scope of work, but just to remind everybody, but Katie, you reminded me of it, so thank you. I'll mention it again, just to keep it everybody's sort of tip of their cortex, is we really have very little good understanding of what happens to the endocannabinoid system in different cohorts of individuals, very young, middle-aged, older adults, different conditions, different drugs, different doses, different exposures. What happens to the endocannabinoid system, which is indigenous, if you will, it is essential to our homeostasis in many, many ways, including cardiovascular, thermoregulation, sexual function and reproduction, mental health and mood, all sorts of things, to name just a few. And we're working in a really big, in a different kind of, this is not a black box warning, this is a big black box warning of what happens to our homeostatic mechanisms with exposure. We learned very much the hard way with opioids, how vigilant we need to be and how difficult balancing those issues are when there is medical need. We just don't want to keep falling into that same trap. So this is something that's, I think, will ever be on the back of our minds, should be in the back of our minds in this. But anyway, that's one thing we didn't really talk about, but it's a level of science that clearly needs further, and physiology that needs understanding. Any other additional thoughts about this topic? That was a really very robust discussion. Thank you, everybody. Okay, Katie, just put in a little word in, thank you. All right, so from there, we're going to just have a brief discussion about future educational events. The first one that's on the list is one that's we've been thinking about for a while. And just to give a little history of this to those of you who may have not been on this, maybe about 6 months ago, it struck me that we were moving to replete the board with a few new members. And with every time the membership cycles, there's sort of a shared knowledge that we have to move forward. And it struck me that we had yet really to bring any reasonable level of knowledge, at least as I was concerned, about all the processes involved from the initial agricultural and processes of growing, the different chemovars, the conditions of growing, how the extraction of materials, the processing, the quality control measures, and then finally the products that are then in the pharmacies, the registered pharmacies in the state, and what those products look like and how they've been tested and how aware we are of what people are getting, and then how to understand how those conditions are being followed in terms of our database. So it's really a soup to nuts process of what's going on here. And here we are, the cannabinoid product board, and we've never had a full-fledged education about this soup to nuts process of the product. So that was the idea. And then Rich took that on, and what we did not want this to be, we knew what we did not want. We did not want this to be a commercial venture. We did not want to be only one group's view of things from, we wanted to separate this from any perceived or real, especially real conflicts of interest, and to put a little educational program together for the board and for the compassionate use board, so at least we could start off understanding this. And if we understood it, then we could then share that understanding maybe more broadly. And so we've been trying to put this together. And Rich, if you want to sort of pick up the thread there of where we're thinking of going and any other.
So it looks like we'll be scheduling something for mid-November. We wanted it to be after the close of the request for proposals for the rural medical cannabis pharmacy that the legislature has required that we award. And we opened the application period up. And as we did that, we realized that it wouldn't be prudent to for the board to go visit one of the processing facilities because of the fact that there's at least at the very on the outside the appearance that that there could be some conflict of interest there. So we've thought, let's shift that to mid-November. And so Melanie Shepard will be scheduling that with the group, and that'll enable board members to plan ahead. And we really do appreciate, I know initially we were planning on doing this in early October, and then we've just rescheduled that, but we appreciate board members letting us know when their time is available so we can identify the day when the majority of board members will be available. And so that should be in mid-November, and Melanie will send out a notice soon. So that's a little more information about that.
And I suspect that after we have that little confab, we as a board who participate will have far more informed and better questions to ask going forward. So this is not one and done. I think this may be an ongoing process where we can refine our understanding, our questions, and through that actually contribute constructively to the process by which different products find their way into qualified recommenders and consumers. So this is a multi-pronged sort of approach towards education, but it starts, I think, with our understanding, because I feel pretty darn ignorant, and the one thing I hate feeling is stupid. There are certain domains I know I can't help it. I will always remain, and I'll be humbly. But if I can be smart about things, at least that I'm supposed to be somewhat responsible for, that'd be I think you'd all agree that would be a good thing. So with that said, boy, we just put a lot into an hour and 20 minutes. We schedule 2 hours for these meetings, knowing that trying to be as effective and efficient with your time. I don't mean to speed things along quicker than our ability to process them or have reasonable discussion, but your time is valuable, so I don't want to take more of it than necessary. What I foresee, just as my thinking as the chair for the remainder of the next, I guess, 9 months, I guess, or so, whatever it is, that I would love to see a time when we can actually gather in person and have a little celebration of having survived Zoom, no less, this horribly virulent virus. And but I think we've also learned a lot from being able to meet in this way, as a way of being more efficient with our time, and as well as environmentally conscious. So what I foresee maybe as a mode going forward is that we would meet maybe quarterly as a board in one place at the health department, so we can see each other interact. There's always sort of a magic that I can't explain that happens when human beings actually share a space, consume oxygen and each other's carbon dioxide together. But then maybe, in between, on a monthly basis, convene in this manner, and that way it'll save a lot of driving and a lot of time getting there and back. And that might be a much more efficient, but still maintaining a high degree of effectiveness as well as what we do. Always welcome your input and thoughts about that sort of thing, or share with me or Rich or Dr. Woolsey or Melanie or Sarah Ponce, anybody you feel comfortable communicating with about how these things go. And again, it's always very helpful to have public, especially public and consumers and medical professionals who want to actually participate in person and have their voices heard. They're the object of our preposition, if you will. And so to ask people to come on a monthly basis a lot, but maybe quarterly or biannually or annually, it'd be a good thing. So any additional thoughts about that? Willing to entertain them. And then we have our public comment. Just open up the discussion for any and all commentary that people want to bring to the
Dr.
floor.
Fine, before we go to that, is there any additional discussion that we want to have about the annual report? I know it was posted on the public notice website, and I suppose the final version of that will be evaluated at October's meeting, because there's the November 1 deadline. And I know there's some things that we wanted to take from today's meeting to incorporate in there. But is there any thoughts from board members about having reviewed that they want to share at this point? It's fine if they want to save that until our October meeting, but I'm just raising that just because I know that annual report was one of the handouts for the meeting.
Thank you, Rich. I just had one minor edit for us to consider, which was, I think it's on the second page and it has the current board members. I noticed that it still has Dr. Wilcox on there. I wonder if we wanted to consider modifying it so we have maybe like current and former board members, so it reflects the news cycle of individuals who are on the board.
That's a wonderful idea. Immediate past board members would be,
Yeah, Melanie, let's visit and talk about how to reflect that in there. That's a good idea. Thanks.
Yeah, because there were two, I think, that were on during that period of the document. But yeah, they are former now, so we can address that.
Yeah, Dr. Crookston too, who contributed a lot. Yeah.
What I like about that idea, Lauren, as well, is it sort of rolls forward and makes a historical record that's easy to access. Because oftentimes a lot of people's efforts and work that, especially at the inception, which was a lot to get this going, I would foresee maybe in a few years being able to write sort of a historical piece about the development of Utah's medical cannabis center and program, and what we, lessons learned. And, these are important sort of learning opportunities, and to have ready access to not just current, but past board members and their credentials and their involvement would be really great. So this would be a good way of doing that. Just rolling it forward. Thank you, Lauren, for that.
Great. We'll reflect that, and maybe we'll just separate the current board members from those that served and who have since rotated off during the past year of service. So great.
Any other departing words of wisdom? hearing none, I'll assume that we are replete with wisdom, and I'm just glad to see everybody's bright, shining, smiley faces and no hacking or coughing, which the smoke is cleared. Hopefully, everybody's staying safe and healthy, and I'm appreciative of that. So go forward in great health, buen salud, and I'll see you guys in a month. Bye.
Bye.
Thanks, Perry.